Dr. Ben Menachem, it's my understanding that Stiripentol is in use in Europe and other parts of the world, but it's not available in the United States. However, in your experience, what are the main indications for its use, and what are the concerns that a clinician should have in using Stiripentol?
Yeah, well, Stiripentol, if I can just go back a little bit and tell you that it was developed in the 1980s. So in Europe, it's considered quite an old drug and not at all a new drug. And it's developed for the treatment of Dravet syndrome. So it's a niche drug that is not used for other indications. And in America, one can obtain this drug through a individualized IND for compassionate use, and often the insurance companies will pay for it for Dravet syndrome. So that's the indication, is Dravet syndrome, and especially when patients are taking valproate and clobazam at the same time, because the clinical trials were done in patients who were on valproate and clobazam. Can you use it when they're not on clobazam and valproate? Surely, but the evidence is with those two concomitant anti-epileptic drugs.
And do we know anything about the mechanism of Stiripentol in Dravet or in any other type of epilepsy?
Yeah, well, the mechanism is a GABAergic mechanism, and it binds to the GABA-A receptor like phenobarbital does, and it also may, there's some indication that it may just increase GABA in the brain, so that it's a GABAergic, increasing GABA drug. And it is has a pharmacodynamic effect with clobazam, which is a benzodiazepine, and the GABA response is double with the combination of clobazam and Stiripentol.
And what about the toxicities of Stiripentol? What kind of issues should the clinician be thinking about?
For Stiripentol itself, it doesn't seem to have a lot of side effects, but it's the interactions, because Stiripentol is metabolized in the liver enzymes, glucuronidation, and cytochrome P, especially cytochrome P2C19 and 3A4, and that's a lot of our other anti-epileptic drugs, including valproate with glucuronidation and clobazam with the cytochrome P. And so Stiripentol inhibits these cytochrome P450 enzymes. And therefore, for example, if you give Stiripentol, the concentration of clobazam will increase double or 3 times. And therefore, then the patient might get hypertonic or hypotonic or sleepy, or hyperexcitability can occur, and therefore then you have to reduce the concomitant anti-epileptic drug, not Stiripentol.
And is there also a pharmacodynamic effect on toxicity, so that because you're affecting the same targets?
That's the whole thing. So people wonder, is Stiripentol a effective drug in itself, or is it a facilitator of the other drugs that the patient is already taking? We don't know that, because there's been very few trials.
Can you give us an update on vigabatrin, especially the safety profile for vigabatrin?
Well, we know about the safety profile. There are no surprises when you use vigabatrin. We know that otherwise the safety profile is very favorable, except for the fact that it can cause peripheral visual deficits or visual field losses. And usually, and I've been using this drug for the last 30 years, the visual field deficits were discovered in 1997. So most of the time these visual field deficits are asymptomatic. We have very, very few patients who have become legally blind because they've had only central vision. But the central vision is always there. They never really get blind, but most people, there's about a 30% who will have some type of visual field deficits based on the European data. And the visual field deficits will be about 30% of the visual field. Now that's the big problem with vigabatrin. Otherwise, we thought it was going to be the perfect drug when it came out. In animals, you see you see microvacuolization in the myelin sheath. And this, however, is reversible, and there have been some studies or some cases, children, pediatric cases, that have shown this, and they have disappeared when the drug has been stopped. What does this mean? We really don't know.
And in which patient populations are you thinking now that vigabatrin may have the greatest use?
Vigabatrin is the first drug of choice in my world for infantile spasms if the child has tuberous sclerosis. Then they usually respond to vigabatrin, and that should be tested first before giving ACTH. With the other cryptogenic infantile spasm cases, probably ACTH first and then vigabatrin if it doesn't help, or a combination of the two is very okay as well. And then for the very refractory patients with focal onset seizures, vigabatrin can exacerbate seizures for idiopathic generalized seizure syndromes like JME and absence. This is definitely not a drug for those type of seizure types.
But for partial onset seizures then,
yeah,
where in the life cycle of pharmacotherapy of the medically refractory patient do you place vigabatrin?
Well, I used to place vigabatrin as the absolute second drug because it was so easy to use. Patients didn't have a lot of side effects. I knew that it was going to help or not help within about a month or two. Because vigabatrin is a drug that either it works or it doesn't work. And if it works very well. And so we always knew at the very beginning. So patients never had a long exposure if it wasn't going to work. So I today would use it because of the visual field deficits, probably the fourth or the fifth line drug. I mean, most of the newer anti-epileptic drugs should be tried first before going on to vigabatrin. But then with vigabatrin, you need to do the visual field testing at baseline and then follow up. And we think we know that nothing really happens for about a year. And so therefore you have a window that you can test this drug. And often you don't have to test it more than 3 months. And if it doesn't work, they stop. And if it works, then you have to, start really concentrating on the visual fields.
Well, Dr. Ben Menachem, thank you very much.
Yes, it's my pleasure. Thank you.